Hello, my name is Eric Williamson. I'm the current president of the Society of Cardiovascular CT. I'm joined this morning by my co-moderator, Dr. Leslie Shaw, former SCCT president. Welcome, Leslie. On behalf of myself and Dr. Shaw, it's my pleasure to welcome you to this, which is the second in a two-part webinar series discussing the recently published 2021 Multi-Society Chest Pain Guidelines. The first webinar, I think that was last Friday, dealt primarily with the implications or ramifications of these guidelines for patients with acute chest pain. Today's webinar will be focused primarily on patients with stable chest pain. As with last week's webinar, we are extremely fortunate to be joined by a panel of distinguished speakers. In addition to Dr. Shaw, you'll be hearing from Dr. Martha Galati, who is the lead author of the aforementioned guideline. You'll be hearing from Dr. Ron Blankstein, another former SCCT president. And finally, but certainly not least, you'll be hearing from Dr. Ajay Kirtani, who will be giving us, say, the interventionalist cardiology perspective on the guidelines. I'd like to welcome all of our speakers. As everyone on this call is likely aware, these particular guidelines have been hotly anticipated in our community over the last several years. We have a lot of material to cover today, and after my introduction, looks like we've got about 56 minutes to get to all of it. So without any further ado, I'd like to reintroduce our first speaker, Dr. Martha Galati, who will be explaining to us what precisely is new about the 2021 guidelines. Martha?
Thank you so much for having me, and thanks to SCCT for hosting these and getting the word out in such a great way about the guidelines. So yes, I'm going to address quickly what's new related to stable chest pain today. So I have no disclosures. So the first thing is, what are these guidelines? I think one of the newest things is these are the first chest pain guidelines, and these are the first symptom-based guidelines to ever be released. One might argue that the syncope guidelines were also symptom-based, but I think of that more as a diagnosis. So that's the first thing that's new. The second thing that I think is new is how we've defined coronary artery disease. No longer is coronary artery disease just obstructive coronary disease. And anybody who's heard me talk in the last 10 years would know that this was probably one of my missions, because for so much time that has been the overt focus of our other guidelines, like the guidelines for stable ischemic heart disease. We're really having a focus on obstructive coronary disease. In this guideline, we revised the term to include non-obstructive atherosclerosis or plaque and obstructive coronary disease to mean coronary artery disease. And our intent was really to ensure that those who have lesser degrees of stenosis, who may not require any coronary intervention, but would benefit from optimizing their preventive therapies, that these people do not get overlooked. Also, our guidelines are patient-centric. They focus on the patient from the beginning. One of our first statements is that the patient-centric nature of our guidelines. In addition to us basing our test choice on the patient in front of us, using their symptoms, using their age to help us decide whether or not they might have obstructive coronary disease, and making a choice on what type of testing, and taking into account if they've had prior testing and cost considerations. In addition, we take into account the expertise and availability at site centers, and of course we involve the patient. There is a big section within our guidelines on shared decision making. So you've probably seen this from, if you were here last week, this lovely triangle that kind of outlines things for what type of testing. We'll ignore the acute chest pain because today we're going to talk about stable chest pain. But this is at least a way to quickly illustrate our focus on the symptoms and the patient in front of us about what type of testing we might choose. And we, again, focusing on the patient, we want to choose the right test for the right patient. So it really depends on the person in front of us. And others are going to dive into this in more detail. So I just wanted to highlight a few things, what would favor the use of CCTA, again, younger patients. And we know we are testing more and more younger patients. When we want to rule out obstructive coronary disease, or we want to detect non-obstructive disease, this might be the reason to use it. Of course, we always say that you need to have that expertise at your institution, at your hospital, at your clinic, and you want it to be of high quality. Otherwise, there's no point in doing the test. You might favor stress imaging if you're looking for ischemia, if again, if they're older patients, and if you've already had a CCTA and the test result was inconclusive. But if you're looking for scarring, again, this is perhaps a better test. We take into account, though, the pretest likelihood of coronary artery disease. And again, a lot of it's based on the age of the patient, but also the question at hand. So those things should be considered when you're choosing the test. Another thing that's new in our guidelines, and this got emphasized last week as well, because it's part of both the acute and stable chest pain, is that when you have a low risk patient, testing is not routinely needed. And at least you can defer testing as well. So this is, I think, one of our top 10 messages that, first of all, we define low risk patients, but also that we use what the pretest probability of our patient is, that I know Dr. Blankstein will get into a little bit more. But ultimately, that not every patient needs testing, and it really depends on the patient in front of you about the decisions you'll make about doing specific tests. So you can just see here, we're going to dive into this a little bit more, but just so that you know, like when you have a patient with stable chest pain and no known coronary disease, after your clinical risk assessment, you decide somebody is low risk. You can see that it's a class 1 recommendation to do no further testing. And this is important for us to know because, again, depending on where the patient presents, you can either say that we don't need to do anything now, or we can do something later as well if there's still some question about what's going on with the patient. I think it's also important to focus on things that might not be always as clear. We talk about chest pain guidelines, but there is a huge focus on prevention woven throughout these guidelines, both primary prevention and secondary prevention. Again, if you just look at these flow diagrams, and hopefully you'll get time to dive in and read the whole document, but when you've identified somebody as intermediate risk who has stable chest pain and no known coronary disease, you can see some of our first recommendations after even if you've done testing. Once you've decided that somebody has mild ischemia, the first class 1 recommendation is to optimize preventative therapies. Even for moderate to severe ischemia, that is the same recommendation. If you can't, after optimizing therapies and they still continue to have symptoms, then maybe you'll choose a different pathway. But as the more recent contemporary research has shown, there's no reason to run to other imaging first, that after that point, medical treatment is important. And even for the low risk patient, we had a class 2 recommendation for coronary calcium or for exercise EKG in the low risk patient, because often we want to know what's going on. Why would this person have chest pain anyway, stable or not? And it helps the patient know what's going on. So you may want to do a coronary artery calcium test. You may want to do a stress test where you put them on a treadmill to measure their exercise capacity to give us important prognostic information, and also excluding myocardial ischemia to help the patient too, additionally, know what they can or should not do. So other things that are new is the idea about ANOCA, again, the non-obstructive coronary disease. And I think this is an important area that we really haven't had enough information about what people should do. So we provided it here, both within the recommendations that focus on non-obstructive coronary disease. Of course, we need more research in this area, and most of the recommendations were class 2 recommendations. And you can see here, we outlined a pathway, an approach towards working up patients with ANOCA. And I won't dive into this, it's a lot of details, but I think that it's important for people to recognize that this occurs frequently. It occurs more frequently in women, but we also see it in men. And we really do need additional workup for these patients. So I'd like to end by acknowledging my co-authors, many who are on this call, and all the societies that joined us in this very long mission. I know you heard already we were waiting for some time for these, but I hope you'll think that we got it right after 4 years. And so now I will pass it over to Dr. Blankstein.
Thank you very much, Martha. Really fantastic talk, and thank you for all your leadership of the guidelines and for being here today with us. I'm going to talk a little bit more about how we evaluate patients with stable chest pain, specifically focusing on patients who do not have known coronary disease. And I'm going to address 4 questions. 1, does my patient need further testing? 2, how would we select between coronary CT angiography and stress testing? 3, if a patient does need a stress test, how can we select between the different options? At least what does the guideline tell us? And because this is an SCCT webinar, also some tips about patient management once a coronary CTA has been performed. So let's turn over to the first question, which is, does my patient need further testing? And of course, it all starts with the history and presentation of our patients. And the terminology now we use is cardiac, possibly cardiac, and non-cardiac. And based on the description and the clinical history, we can decide if the patient is having cardiac or possibly cardiac symptoms, in which case they may benefit from testing. And of course, there are symptoms like pleuritic or positional pain that may indicate non-cardiac pain. And you can refer to table 9 for a very exhaustive list of all the different non-cardiac etiologies that you ever wanted to know about. So let's say the patient does have cardiac or possibly cardiac pain. Next, we may want to look at their pre-test probability. And this is the recommended algorithm for that, which is in the guideline. And the question is, based on the pre-test probability, how do we know if the patient requires further testing? And the answer is, if they have a low pre-test probability of obstructive coronary disease, which is defined as less than 15%, these are patients in whom testing can be deferred. Now, deferred doesn't mean that they might not need testing in the future if they present again, but at least for the purpose of evaluating them at the current time, that can be deferred. And low pretest probability in this table are all the cells that are in the light green here. Another option here is to also use calcium scoring, both for better definition of the pretest probability. And also, if you have a low risk patient, it is optional to do calcium scoring or an exercise treadmill test. Both of those tests now have a 2A indication in low risk symptomatic patients. There are a couple important points that I think we all need to understand when it comes to this pretest probability table. First, the estimates in this table, similar to the estimates that are offered in the European guidelines, are significantly lower than prior versions of prior guidelines, at least 50% lower. And that has to do with the fact that in the contemporary era, the majority of patients who we see with stable chest pain do not have obstructive disease. In fact, the rate of obstructive disease is less than 10%. The rate of ischemia is far lower than that as well. The second point is, this is based just on the age of patients, whether they have chest pain or dyspnea, and whether in the sex of the patient. And if you look under chest pain, there's a less than or equal to sign here. And that has to do with the fact that what we did here is we looked at the whole range of whether the patient has cardiac chest pain, what previously we used to call typical angina. And that is the upper range of the estimate, which is shown here. Of course, if the patient has possibly cardiac chest pain, that will be lower. So the numbers here represent the upper end of the spectrum, and that's why there's a less than or equal to sign next to each cell here. And I want to point out that this is based on a very nice paper by Wars, Orozco, and colleagues, and this is the same paper that actually informed the European guidelines. However, in addition to that, we also offer another option for determining the pretest probability, which incorporates information on calcium score, if that is available or if that is performed, realizing that not all centers are going to perform that. But if a calcium score is available, if it is 0, that is consistent with a low pretest probability. And if that score is elevated, the higher it is, the higher the likelihood of obstructive coronary disease. So the addition of calcium score is very helpful for defining the pretest probability. In fact, multiple papers have shown that. The third point that I think is important for us to understand is that we now have a low risk group, and all the other patients are put together in a single group, which is the intermediate to high group. And many individuals ask, well, why is that? What's the rationale? And it's twofold. First, if you look at this table, it's very hard to define here a high risk group, because all patients here, with the exception of men with typical angina, or what we now call cardiac chest pain, over the age of 70, they have a probability that's 52% or higher, or I'm sorry, 52% or lower. The rest of the cells here are all far lower than 50%. So it's hard to find a high-risk group. But more importantly, even if we were able to identify a high-risk group, in prior guidelines, it was suggested that high-risk patients should go directly to invasive angiography. And today, that's no longer the case. We now have studies both from coronary CTA, CT-FFR, stress MRI, and nuclear perfusion imaging that even in high-risk patients, if you start with a non-invasive test first, fewer patients end up in the cath lab, costs are lower, and outcomes are similar. Let's turn to the next question, which is how would we select between coronary CTA and stress testing in patients who do not have known coronary disease? So of course, we are going to focus now on this group that's intermediate to high risk. And if we look at this group, the guideline provides two indications, both being class 1. The first one is that the use of coronary CT angiography is effective for the diagnosis, risk stratification, and for guiding treatment decisions. And then stress imaging, and particularly this is imaging, so exercise treadmill test is a 2A, whether it was echocardiography, SPECT, PET, or MRI, is effective for diagnosing ischemia and for estimating future risk. Of course, the natural question, and one which I think is very difficult sometimes to answer, well, how do we select between these options? And if we put this in the figure, you can see here that there is an option to do either a CT or to do a stress test in this situation. Now, one of the things that I want to dive into is what are some of the recommendations that we put in the guidelines. Some of this is in the text, some of this is in the footnotes to some of the figures. And it's as follows, that CTA is preferable in those under the age of 65 who are not on optimal preventive therapy. And this has to do with the fact that the majority of patients in this group are going to have non-obstructive disease or normal coronary CTA. So this gets into the opportunity to detect plaque and enhance prevention, which is one of the advantages of CT in this setting. It doesn't mean that you have to, and this is not a formal indication in the guideline. There's no class of recommendation here. This is a suggestion that's offered in the text and footnote to tables. And similarly, on the right side of this slide here, stress testing is favored in those who are over 65, and that is because they have a higher likelihood of ischemia, a higher likelihood of obstructive disease, and also a higher likelihood of having significant calcifications. This information is specifically referenced with respect to patients with stable chest pain. There are also, for both stable chest pain and acute chest pain, factors that may favor the use of CT over stress testing, and you can see them on this slide here. And of course, they have to do with the ability to obtain high quality imaging and expert interpretation that underlies everything else here. Obviously, if a center is unable to provide coronary CTA, another test will be favored. And I want to emphasize that the age here, we get a lot of questions on this. This is just a factor that would favor the use of one test over another. There's obviously patients who are under the age of 65 in whom a stress test would be a better approach. And vice versa, patients over the age of 65, particularly if we know they don't have a lot of calcifications, and particularly women in whom coronary CTA may be reasonable. So this is not an absolute criteria, and I want to make that point clear. So let's say we decide that a patient needs a stress test. How do we select between the different stress tests? First, we have to consider local availability and expertise. Not every test is available everywhere. Second, we have to consider the patient characteristics and contraindications. And there's a long list of contraindications for each modality in the guideline. Third, shared decision-making is encouraged in that. So that obviously depends on what is offered at a particular site. The fourth point here is that exercise is preferred, and this is particularly true for SPECT and for stress echo, because with MRI and with PET, there are unique advantages, and exercise is not an option. So it's not to say that these are preferred over MRI and PET, but if a modality can be done with or without exercise, in that setting, exercise is preferred. The next point is that PET and MRI have a unique advantage of quantifying myocardial blood flow and blood flow reserve. And that is particularly helpful if we're looking for INOCA, which Dr. Galati talked about, and that is also helpful if we're trying to detect microvascular disease. There's also an indication that PET is preferred over SPECT. That's a class 2A indication for the preference of PET because of its higher diagnostic accuracy, better prognostic information. And lastly, a recommendation to add on calcium scoring if stress testing is performed, particularly in patients who do not have prior known coronary disease, knowing that that can improve prognosis, diagnosis, and lead to the initiation of preventive therapies. So for the last question that I want to go through is, how do we manage patients after a coronary CT angiogram has been done? Certainly, if a CT is inconclusive, stress testing can be done. In a similar way, if a stress test is inconclusive, there are recommendations that CT can be done. Once a CT was performed, patients who have plaque require intensification of preventive therapies. Patients who have either extensive non-obstructive plaque who are symptomatic, those are patients who can be evaluated for INOCA, ischemia without obstructive disease. And the guideline states that there are various types of stress tests that can be performed for this scenario. That's a 2A indication. Or if there's obstructive disease, in that case, also, there's an option to perform either a CT FFR or stress testing. FFR CT specifically is reserved for lesions that are between 40 to 90% that are in proximal and mid locations. And stress testing can be performed across this range as well. Now, one of the important points about this is that this does not mean that if you have an obstructive lesion that you have to go on and do a FFR CT or you have to do a stress test. This is an optional test that you can do. And if you want to decide whether that is needed or not, I think one of the really important points is at the very bottom of this figure, and that is that follow-up testing and intensification are guided by test results, but also the persistence, worsening, and frequency of symptoms. So if you have a patient that does not have significant symptoms and infrequent symptoms, even with obstructive disease, you do not need to do any further testing. On the other hand, a patient with obstructive disease that has frequent symptoms, this is where evaluating for ischemia is an option with a 2A recommendation. In fact, the only group here that should go for invasive angiography after a CT are patients who have high-risk coronary disease, and you can see those defined on the right side of the slide here. Those are patients with left main disease or multivessel disease, or patients who have frequent angina. So this is the only group that goes directly to invasive angiography. In other patients, stress testing or FFR CT is encouraged. Thank you very much. Again, honored to be part of this, and I will turn over to Dr. Leslie Shaw next.
Thanks, Ron. Really appreciate that. It was just an outstanding talk. And I'm going to talk about the patient with known coronary disease. So we'll move along in the guideline and highlight the issues around the known coronary disease patient. Sorry, just for a minute here. Not sure why. There we go. It's not advancing. I apologize. Whoops. There we go. So I'm going to talk about the key highlights and what's new in the guideline. First, in the patient with known coronary disease, there's an emphasis on intensifying guideline-directed therapy and taking a pause on whether or not you refer the patient to additional testing whenever possible. Martha talked about this whole concept of redefining, and I'll give you my little twist on it. The inclusion now of patients that have evidence of atherosclerosis. And of course, there are no guidelines for non-obstructive disease, but at the last slide, I'm going to focus a little bit on some potential data, which may be very helpful to you. And then whenever possible in this patient with known coronary disease, there's an emphasis in the guidelines to treat the patient for their anginal symptoms, to have optimal and optimize anti-anginal therapies and preventive therapies with the primary goal, based upon all of the randomized trials, of reducing the patient's angina burden, using targeted risk factor modification and intensification of preventive therapies to improve patient outcome. And here you see the first stop, and it is that focus on taking a moment to see if that patient with known coronary disease is on adequate guideline-directed medical therapy, oftentimes our reflex decision is to send the patient with known coronary disease back to a test, and oftentimes to a stress test. And so this is a moment for you to say to the patient, sometimes it takes a little while if you have persistent symptoms for us to get your medical therapy titrated appropriately. And this is that time to have that discussion with the patient. Now, as Ron talked about, there is a direct line to invasive coronary angiography in the patient with known coronary disease, particularly if they have high-risk coronary disease. That's three-vessel disease or significant left main stenosis, or if they have frequent angina. I'll talk about that. And again, the emphasis at the end of guideline-directed medical therapy. It's persistent throughout this, which is an important focus. And of course, I think remember the ischemia trial results. It was a lot going on in ischemia. Some of you may not be familiar with all of the data, but patients were randomized who had moderate to severe ischemia, and they were randomized to an invasive approach versus conservative approach. The prominent result from the ischemia trial is that patients who are randomized to the invasive strategy had a prompt and durable improvement in angina through 3 years of follow-up. The patients who had the greatest improvement in symptoms were those that had daily and weekly angina. Those that favored an invasive strategy. So the question that you might ask yourself in this patient with frequent angina is skipping that stress test, going directly to invasive coronary angiography, and using FFR or IFR as needed to guide coronary revascularization, a reasonable conclusion that was emphasized in the guideline. And of course, you may not have seen this paper from ischemia. Myself and Harmony Reynolds wrote this, showing that ischemia severity was not predictive of any treatment interaction. And this is an important paper, as we're seeing unfolding consistently in the known coronary disease patient population. The severity of ischemia is not really a deciding factor in terms of risk or treatment effectiveness. But we do see in ischemia an emphasis that very high-risk coronary disease, again from Harmony Reynolds' paper, the patient, and you can see that this blue box on the upper left, the patients with three-vessel disease or two-vessel disease plus proximal LAD had a benefit with revascularization or an invasive strategy. Again, reinforcing in the guideline, direct angiography in that patient with high-risk coronary disease. And this is supported by ischemia data. Now, focusing, again, what Martha talked about, which was really, to me, a fascinating twist, is that we used to define known coronary disease as just a patient with significant obstructive disease. But we know that atherosclerosis is a progressive disease. So understanding what the needs are for patients who have mild coronary disease, who have evidence of atherosclerotic plaque, we're now entering into a much more prevention-focused approach to our populations at risk of obstructive disease. But now these patients are also the patient who is defined as having known coronary disease. Now, a patient has known coronary disease. If you follow down this clinical decision pathway, you see that there is an option, if they have persistent symptoms, to consider the use with a two-way recommendation, CTA and potentially stress testing or FFR to evaluate the functional significance, but primarily to consider the use of CTA to assess progressive disease. And I want to talk a little bit about that on the next few slides. So here was our landscape on our traditional definition of obstructive disease. It's way at the end of the continuum of patients who have coronary disease or have evidence of atherosclerosis. And that threshold was so high. And there were so many patients starting at figure number 2 to 4 on the top slide that actually had evidence of atherosclerotic plaque. This is a progressive disease. And really, most of the time, these lesions aren't detected with stress testing. But now, as we look on the lower slide, our new definition, we are really focusing on the treatment and particularly prevention in these groups. But also, I might add for you one additional thought, and that is, we know from the angiographic literature, patients who have ACS, about 2/3 of the time, if they have a prior anatomic study, about 2/3 of the time, those are patients that have documented mild stenosis. This is fascinating. So we can pick that up and we can identify really the pool of candidates who are at future risk of ACS with the goal of intervening in intensifying preventive care therapy to avert that downstream risk. And we know from CTA that there are specific high-risk features such as positive remodeling, low Hounsfield unit attenuation plaque napkin ring sign, and spotty calcification, which is all based on the prior invasive angiographic markers, that these markers in lower risk patient populations, risk stratify, notably from PROMISE as well as from SCART Heart, these markers are showing at risk for future ACS. And even in SCOT Heart, if the patient had non-obstructive disease and had a bigger burden of this low Hounsfield unit plaque, that is a plaque burden of greater than 4%, their risk of incident myocardial infarction was almost sevenfold. That's amazing. And so I think we have a lot that we can understand about and the future risk of this patient, and therefore intensification of therapy is important. Of course, we don't have guidelines for non-obstructive disease. We don't have a lot of randomized trials, and hopefully that will come in the future. We can learn something on how to treat patients with non-obstructive disease from SCOT Heart, and this is my last slide, to emphasize that the protocol in SCOT Heart recommended in patient with non-obstructive disease and obstructive disease, statins and aspirin therapy. And of course, that's postulated as to one of the reasons why at 5 years, there was a reduction in death or myocardial infarction in the SCOT Heart patients. Of course, we would like to see some more therapeutic trials in this area, but certainly this is something to think about in the patient with non-obstructive disease, again, reducing their risk of future ACS. So this is my last slide, and I'm really excited to hear what Dr. Kirtani has to say, one of my colleagues from across New York City, who's taken time out of his busy schedule, and we look forward to hearing from him. So thank you so much for all of your attention. I think you need to unmute Ajay. Sorry.
Can you hear me now?
Yes, we can. Thank
Perfect.
you.
Yeah, the host had to let me do it. So sorry, I'm at the TCT meeting down in Orlando, and it's actually just an honor to be part of this webinar. And frankly, I think it's good timing because for interventional cardiology, historically our space has been one where I always talk about it as a procedure where there's a diagnostic portion and then there's the interventional portion as appropriate. And I think what's really welcome about these guidelines, and it's nice that this is being sponsored by SCCT, is that basically the diagnostic portion can be encompassed by CTA. And that's something that I think a lot of interventionalists might not grasp initially, but over time they will. And certainly in my practice, that's one way I've been able to, I think, manage patients much more effectively. And hopefully I'll give you some broad strokes of that. I think also the prior speakers have very, very nicely gone through the specific algorithms. I have big slides and sort of big picture ideas from an interventional perspective, but you'll see there's a ton of convergence with regards to what we're all going to talk about. So I just started here, and I've just used the ACCHA slide deck, and this is freely downloadable, by the way. You can go online, download the entire deck. It has all the indications. You can use it for your own purpose. But I think that just a big general principle, and this is one that we try to emphasize to our fellows all the time, is that those patients that really need to come for an invasive procedure, or even frankly upstream of that, non-invasive testing, are those who are intermediate or intermediate to high pretest probability. This basic idea, Bayesian idea of looking at the patient, determining what their probability of disease is, really ought to guide the testing strategy, because I see so often people go down this pathway where they've had 4 different tests done. And if you were to take a step back and understand why the patient went for testing in the first place, you might realize that 3 of those 4 weren't needed. Maybe all 4 weren't needed. And it's that pretest probabilistic assessment that's so important. And as interventionists in the lab, making decisions about the treatment of these patients, that's really, really critical to the way we like to think. This is a big general figure looking at how we think about these probabilities and then how we determine which tests to do. The color coding scheme is fantastic in these guidelines, where essentially asymptomatic patients, green, meaning no testing, low risk patients, similarly, you don't typically need to test. And on the acute side, those people are likely higher risk and are likely going to go to the cath lab. The thing is, this webinar today is talking about stable ischemic heart disease. And for those types of patients with stable chest pain, generally speaking, they really don't need to come to the cath lab if there is good upstream testing that can appropriately risk stratify those patients. Beyond risk stratification, we've heard a lot about anginal relief and GDMT. Can't emphasize enough how important those things are to prevent adverse prognostic events for these patients. But specifically with regards to testing, it's really only in the super high risk patients, those with such a high pretest probability that you wouldn't perhaps believe an antecedent negative non-invasive test, that you might consider doing catheterization. But the question is, how many of those patients are there out there? That's why I think it's nice to see this slide looking at the pretest probabilities of obstructive disease based upon, age, sex, and symptoms. And this actually updates Diamond and Forrester, where in general, there are very, very few patients for whom, just based upon the clinical pretest probability, they're going to have a super high prevalence of 3-vessel or left main disease. Now, we can argue a little bit about that. There may be specific populations that might have a higher prevalence. I have a slide at the end. I'm an Indian guy. We know South Asians, for instance, have a very high incidence of multivessel disease, so perhaps they're going to be modifiers. But by and large, unless you're a man over the age of 70 with typical symptoms, your pretest probability of having significant disease is not going to be that high. And so that's the whole rationale in these guidelines of doing some sort of testing upstream of coming to the cath lab, which makes sense because the last thing an interventional cardiologist wants to do is a whole bunch of negative diagnostic caths, because A, it's not resource efficient, and B, it exposes patients to a small risk, but a real risk nonetheless. These decision pathways we've already talked about. Essentially, for patients with no known coronary disease, there's a bifurcation. You can sort of, if you're low risk, pretty much not going to test. If you're intermediate or high risk, the bifurcation is to do CTA, anatomic-based testing, or stress testing, which is the antecedent paradigm for most people who are evaluating chest pain. Now, as an interventionalist, I will tell you, I prefer the CTA pathway. And the reason is it quickly delineates the anatomy. It rules out left main disease or bad multivessel disease. And then you can manage the patient because we know anatomy predicts adverse outcomes, as Leslie showed you. The challenge, though, with CTA in clinical practice is that there's reader variability, and then there's also this issue of what happens if a patient or a physician referring sees obstructive disease that's sort of 60% or 70% and then worries, and that's why the FFRCT inclusion in these algorithms is useful, because that test can then prevent patients from ending up in the cath lab simply because of the worry of the patient or the treating physician. The prior paradigm of stress testing is also still manifest in these chest pain guidelines. If you have mild ischemia, or essentially you can manage those patients medically. If there's moderate to severe ischemia, it's typically going to be managed medically unless the symptoms are persistent. The one caveat I will personally make here, it's not in the guidelines, and maybe you can have some discussion on this, is that on the basis of the ischemia trial, there's going to be a fraction of patients, 8% or so in the trial, that had left main disease. And how do we rule that out? And that's why, as an interventionalist, I tend to prefer the CT-based approach, but I'm sure we'll have some discussion about it. The basic bottom line, though, is for most patients presenting, the incidence of left main is going to be relatively low. For those patients that have stable chest pain and known coronary disease, similarly, the guidelines, and Leslie made a great point about the fact that things can change over time. So even if patients have non-obstructive disease, if they have persistent symptoms, they can end up in the cath lab, but typically it's going to be because of a test that was done to sort of rule out progression of disease. There's also a nice slide in the guidelines looking at what the quote-unquote warranty period is for a normal CTA or a normal stress test. Many people have been telling their patients, if you've had a normal study, gives you 5 years or 10 years, it's probably not likely that that's the case. It's probably less than that, particularly for patients that are less well managed. So it's important to keep your good clinical acumen about you so as to know how to manage these patients. If they have had known obstructive disease, especially greater than 50%, you could defer, but if they're high risk or having a lot of angina, then they end up in the cath lab. So that's an important point of these guidelines. We didn't talk about this yet, but there's also a way you can end up in the cath lab to look at testing for INOCA, so patients that happen to have ischemia on non-invasive stress testing, persistent symptoms, and for those sites that are facile at doing invasive testing in the cath lab to guide management, that is in these guidelines as well, and I would just refer you to this figure and the nice discussion about this. The other pathway that makes a lot of sense if there's expertise, though, is to do things like stress PET or stress CMR, and those patients might not have to come to the cath lab at all. So just to sort of summarize, there's some basic principles inherent and encompassed in these guidelines that as interventional cardiologists, I can 100% get behind. And first, it is to tailor your likelihood of going to the cath lab based upon the risk of the patient. So who are those patients? These are patients that other non-invasive testing demonstrates higher risk, whether that's in the ischemia guided manner with stress testing or in the CT guided manner with more multivessel disease or more obstructive disease. That's the first group. The second group are those with symptoms that are persistent despite medical therapy. And that's on the basis of the slide Leslie showed you about the ischemia trial and how we could more frequently relieve patients' ischemia by taking them to the cath lab and managing them that way. There's also the possibility within these guidelines of in-lab physiologic testing if patients don't have prior stress testing or the disease is intermediate on CTTA. You're going to hear from this TCT meeting about questions about whether FFR is useful and that sort of thing. Every test is useful if used in the right patient population. We don't need to do FFR or IFR indiscriminately on all lesions, but if it's going to resolve a clinical problem, a patient with symptoms and yet disease that's not severe, or a patient that has ischemia and disease that's not severe and we're determining how to treat, then in-lab physiologic testing is useful, and that's manifest in these guidelines. And then finally, this last issue of invasive testing for Inoka is addressed with a lower grade of evidence recommendation, but it's still important that this was actually recognized within this iteration of the guidelines. So thanks so much for having me. Happy to move on to the question and answer session. And honestly, for me, it's been a fantastic webinar to be a part of.
Geez, thanks so much, Ajay. That was amazing. Really practical, and just honestly, right from start to finish, just phenomenal talks, and really appreciate it. As we start the question and answer period, Martha, if it's okay, I'd like to start with you. First of all, congratulations on getting this guideline across the finish line. It's a huge accomplishment. You're still on mute, I think. You can't unmute. All right. Well,
You unmuted me. Sorry. So
Okay.
I'm not allowed to unmute. Sorry about that.